Hello students, my name is Mrs. Okorochukwu. I'm going to take you people on fundamentals of nursing, and we are going to discuss today introduction to operative nursing care. Definition of operative nursing care. Definition. We say that operative nursing care is the provision of nursing care to the patient before, during, and after surgery by the nurse. And we have phases of operative nursing care. Phases of operative nursing care. Phases of operative nursing care include, number 1, pre-operative nursing care. Pre-operative nursing care. This is the time from when the decision to do the surgical intervention is taken, and it ends with the transfer of the patient to the operating table. Second one is intraoperative nursing care. Intraoperative. This one starts from the time patient is in the operative table to the post-anesthetic care unit. From the time patient is transferred to operative table to admission into the post-anesthetic care unit or the recovery room. The third one is post-operative nursing care. Post-operative, which starts from admission of the patient into the post-anesthetic care unit or the recovery room to the last follow-up of the patient, either in the clinic or at home. All these three phases of operative nursing care are together called perioperative. Perioperative period. So we move on to types of surgery or classification of surgery. Types of surgery or classification of surgery. Types of surgery. We have three main types of surgery. Number 1 is according to purpose or reason the surgery is being done. Number 2 is according to the risk involved in the surgery. Number 3 is according to urgency. Then what do we mean by according to purpose or reason? By classification of surgery according to purpose or reason, we have diagnostic surgery. Diagnostic surgery. According to purpose or reason, we have diagnostic. This is a type of surgery done to obtain a tissue for establishment of a diagnosis of a disease. Example, biopsy or exploratory laparotomy or even bronchoscopy. You are just doing it to establish a diagnosis. The patient has this diagnosis. Another type of surgery according to purpose is curative. Curative surgery. Curative surgery is done to cure a disease or a condition. Example of surgery under this is excision of a tumor. Once a patient has abnormal growth, you do a surgery to excise it. Or an inflamed appendix. A patient that comes with an inflamed appendix, the body is diseased. So that disease part is now cut off or excised in order to cure the patient of that condition. The third type of surgery we have is reparative. Reparative surgery. Say reparative. In reparative surgery, it is done to repair tissue or organs. It is done to repair a tissue or an organ. Example is multiple wound repair. When a patient has wounds, lacerated wound, you do it to repair it. Or somebody that has vesicovaginal fistula, you do a repair of that vesicovaginal fistula for the organ to start functioning properly. The fourth one is reconstructive or cosmetic surgery. Reconstructive or cosmetic surgery. This is done to improve function or obtain a desirable cosmetic effect after curative surgery. Cosmetic surgery is done to improve function or obtain a desirable effect after a surgery, like mammoplasty or facelift, the type that Michael Jackson did on his nose. This is what we call reconstructive or cosmetic surgery. The fifth one is ablative surgery. Ablative. In ablative surgery, it is done to remove or excise a diseased organ. It is done to remove or excise a diseased organ or tissue. That is, the tissue or the organ has damaged so much that we don't need it anymore in the body. So the thing is, the option is to remove that diseased part, to excise it. That's what we mean by ablative. Example is cholecystectomy, a gallbladder that has stone that is no longer functioning, you exercise it. Or when a woman has cancer of the breast, you do radical mastectomy, you remove the breast, the diseased breast. That's what we mean by ablative surgery, excising the tissue or the organ. Number 6 is palliative surgery. Palliative surgery. Palliative surgery is just done to relieve the patient of symptoms and make the patient as comfortable as possible and promote quality of life. It's not being done either to cure a disease or to heal the patient. It's just done for cancer patients, so that whatever the pains, whatever the suffering will be reduced, the patient will have more comfort and have possible good quality of life. Something like if the patient is having protracted illness and is painful, you can do nerve roots, resection of nerve roots. Or when the patient is not taking enough and there is disease of esophagus or what, you do gastrostomy in order to feed the patient through that place. That's what we mean by palliative surgery. Number 7 is prophylactic surgery. Prophylactic surgery. Prophylactic surgery is done to remove non-vital precancerous tissues or organs. When a woman has lump in the breast, example, and you find out that with years, if something is not done, it might be cancerous. The woman might take decision for surgery to be done, and that part will be removed. That's what we mean by prophylactic. You are doing it so that it will be a kind of preventing future occurrence or complication in the future. Thus, by this, we summarize our types of surgery according to purpose or according to reason it is being done. Say number 1 is diagnostic, curative, reparative, reconstructive, ablative, palliative, or even prophylactic. We are going over to classification of surgery according to risk. That is, classification of surgery according to risk is in 2. Number 1 is major surgery. Major surgery. Major surgery involves a high degree of risk. It's a type of surgery that involves a high degree of risk. It involves either general anesthesia or spinal anesthesia. Patient's life is at danger. So, example of major surgeries are open heart surgery. If you are doing open heart surgery, it involves extensive anesthesia. Something like laparotomy, any of the surgery that involves general or spinal anesthesia is grouped under major surgery. The second one is minor surgery. Minor surgery. Minor surgery involves little or no risk. Little or no risk. Something like in minor surgery, we normally use local anesthesia. You just anesthetize that place so the patient will not be feeling much pain. Example is day case, removal of tooth, something like that. Something that is minor. It does not require either general anesthesia or spinal anesthesia. The third classification of surgery is according to urgency. Classification according to urgency. Classification of surgery. Classification of surgery according to urgency. According to urgency simply means, is it something that will be done immediately? Will we leave it later that we do it? So in classifying surgery according to urgency, we have number 1, emergent surgery. Emergent surgery. In emergent surgery, the patient requires surgery immediately. The disorder is life-threatening and surgery is done without delay. If there is delay, patient lives might be in danger. That's why we group it under emergent surgery, emergency. Something like severe hemorrhage, patient is bleeding heavily, fractured skull or ruptured uterus. If you don't do something immediately, if you don't get the patient to theater, patient might die immediately because of loss of so much blood. Number 2 is urgent surgery. Urgent surgery. In urgent surgery, patient requires prompt attention. Is prompt attention is not life-threatening, but there are priority signs that surgery should be done within 24 to 30 hours in order to save the life of the patient. Something like acute gallbladder infection or kidney stones. Patient requires surgery between 24 hours to 30 hours in order to save the life of patient. Number 3 classification in this order is required surgery. Required surgery, patient needs to have the surgery done within a few weeks or a month. We recall that in this emergent surgery, patient needs it immediately in order to save the life of the patient. If you don't do it immediately within hours or minutes, patient will die. In this urgent one, within 24 to 30 hours, patient needs the surgery. But a required surgery is not life-threatening, it's not an emergency. The surgery can be done in a week or in few weeks. Patient will be prepared. Or even a month. Something like thyroid disorder, a woman that has goiter, that one is not emergency as far as it's not having airway obstruction or the breathings are okay. You can prepare the woman for surgery like for a month, give a month gap or a week's gap before the woman comes. Something like benign prostate hypertrophy, enlarged prostate, the man can wait for like few weeks or a month before you do the surgery. It's not life-threatening as far as the man is not bleeding heavily. Number 4 is elective surgery. In elective surgery, patient should have the surgery done, but failure to have it is not life-threatening. That's what we mean by elective. Example of elective surgery is repair of VVF, vesicovaginal fistula, or atresia. It has to wait for some time before you do it. It's not life-threatening. Number 5 is optional surgery. Optional. In optional surgery, the decision to have the surgery rests with the patient. If preferred, it's not a must that patient will have the surgery done, and it's not life-threatening. If patient does not want it, patient can leave it. Something like cosmetic surgery, like the one of face uplift, classify the surgery. The next thing we are going to discuss now is pre-operative nursing care. Pre-operative nursing care. Pre-operative nursing care is the care you give to a patient before the patient has the surgery. And every care we give to our patient is done using the nursing process. In using the nursing process, number 1 thing we are going to do is assessment. After assessment of the patient, we have a nursing diagnosis. We set our objective. We plan our care. We implement our care. And we evaluate care. We're going to start with assessment. In assessment of our patients, we first assess if the patient has emergency signs, what we call emergency signs. Is the patient having pallor? Is airway obstructed? Is the pulse trading? Is the breathing fast? In emergency signs, we have to think about circulation, think about airway, think about breathing. If everything being all right, patient does not have any problem in these areas, we now move over to what we call priority signs. After we have established the level of consciousness of patient by using AVP. Is the patient alert? Does he respond to voice or to pain? Or is he unconscious or in coma? Having established that, we talk about our priority signs. We've discussed all this when we did our nursing management of a sick child. In nursing management of a sick child, we've discussed this. What we note in priority signs, what we note in emergency signs, then risk factors for surgery. Having established emergency signs, level of consciousness and priority signs, the next thing we are going to do is to take our history. So we say that in our assessment, what we basically do in assessment is to assess. You assess circulation, airway, and breathing. How do you assess the circulation? By feeling the patient pulse, noting if the patient has pallor, what's the BP of the patient, then airway, are there mucus obstructing the airway, or is it okay? Breathing, is the patient using accessory muscles of respiration in order to breathe, to force in air into the lung? If there are signs like this, we say that this patient has emergency sign. If not, patient does not have problem in breathing. So we move over to priority signs. We assess the priority signs. Priority signs, is there a case of poisoning? Is there something that is life-threatening that if not done, patient life is in danger? You assess this and you intervene immediately. Then, all things being equal, if patient is all right in this area, there is no problem, we move over to history taking. History taking. We've discussed about history taking. We start with past medical history taking, present medical history, family social history, in order to get the problems or areas where the patient has issues, in order to make our diagnosis. If you don't do your history taking very well, you might not have any areas you find out that patient will have intervention that requires your help. Then after history taking, we review system. Review of system. Review of system. Start with sensory system, musculoskeletal, urinary system, respiratory, down. If there are areas or any system patient is having problem with, you have to assess it and know. All these assessments of circulation, airway and breathing, assessment of priority signs, history taking, and review of system are the areas you will get your pertinent data. If you don't do this thing very well, you will not have a pertinent data to form nursing diagnosis. But why, if you do these things very well and you get the problem of the patient, the chief complaint, and review of system, the system that patient is having problem with, you have to put the data together, cluster the data in order to form our nursing diagnosis. That's why we move over to nursing diagnosis. Having done our assessment very well, we've done our assessment, the first step in perioperative nursing care. We are going to move over to nursing diagnosis. Nursing diagnosis.